You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. All right. Hello, everybody. This is another awesome episode of the Primary Care PT series. I'm your host, Dr. Katie Obright, and if you're listening to this now, this is going to be coming out sometime in August or September of 2023. And we have a really special guest because by the time you're listening to this, some of the stuff that we're going to be talking about in this episode might already be put into motion, no pun intended. So today we have Dr. Genevieve Correa, who is a doctor of physical therapy out in Hawaii. And she has some interesting things to share about her interest in primary care PT and what she's been up to. So thanks so much for joining us, Genevieve.
Thank you so much for having me. Yeah, I'm glad we can make this work and make it happen.
I know. So we've actually rescheduled this a few times, and we were both kind of going through the same thing. Today, I have 1,000,001 things going on, and my family's about to leave for a trip, and Genevieve is in the middle of her EDD intensives, and we both just decided, like, let's just do it. We're not going to reschedule. We're just going to do it, and it's going to be great. So, Genevieve, tell us a little bit about your background as a PT and why you're interested in primary care.
Okay, so it's weird. I'll start at the present. Right now I feel like I'm such in this development infancy stage of everything. To say that I'm 11 years out of graduating as a non-traditional physical therapy graduate. I did my physical therapy school at University of Pacific. I finished in 2012. Then I jumped right into the PNF residency. So I did the 9-month PNF residency, which was amazing to get my skill set as like a neuro-based clinician, to get my hands, my cues, my philosophy, a lot of the basis of my training, which is very holistic. Then I jumped right into the manual therapy and primary care fellowship at Kaiser Vallejo. Which is now merged between Vallejo and Vacaville. And I love that. That was 21 months. So after PT school of a 25-month program, I jumped to 30 months of postgraduate training. So I would say that's a big basis of my skill set. I worked at Kaiser for about 7 years just to hone in onto my skills. It's like I want to learn more from mom and dad, auntie and uncle, and cousins that have been with the same line of thinking, which is about learning tools, being in the place where we get to learn diagnostics amongst the ER physicians, primary care. So that's where a lot of the basis of my training came. And then I jumped into wanting to travel and visit with family and friends. So I started to work as a traveling PT, which led me to Molokai. I worked at Molokai General Hospital for a little while. All of this background is helpful to understand how I got more and more passionate about primary care and rural health medicine. I worked at Molokai General Hospital for about 7 months as a traveler. Started as 3 months, extended throughout, and then saw the needs of a community. COVID hit. I was adjunct faculty at University of Pacific for 7 years. When I decided to move to Hawaii, they did offer me to teach diagnostic imaging, which was very new to me, but it was a good dabble in the aspects of one of our clinical sets as physical therapists, but then using that as kind of a stepping stone to start really integrating primary care, right? I think a lot of PT schools use it as, here are your ABCs. If you look at an image, what is this, what does it look like? But do we really use it? That's what I've heard a lot of clinicians, except for Gail Dial, who taught our radiograph or diagnostic imaging, and really which he is in the forefront of primary care also. for primary care physical therapy. So kind of seeing that model of, okay, you see this, when are we really going to use it, and how are we going to use it for our people and our community? To fast forward. Then when I came to Hawaii, HPU started their own program, a physical therapy program with a hybridized program with evidence in motion, trying to help rural communities have access to schooling, so that hopefully there's more people from, at least this is my kind of spin on the aspect of an evidence in motion and university kind of hybrid program, is allowing people that don't have access to the education to get those people to have access to care, because we have such a deficit in rural physical therapy, which is also a deficit in primary care, right? So when you kind of blend all of those together, it creates more, sorry, I'm so casual. My dog barking me. She wants to go inside.
Oh, that's perfectly fine. My dog's laying right behind me. So
so it kind of like, it's like talk about seeing where the world brings you, and how I got accepted into these rigorous programs and these infancy stages of academic programs, and to see the needs of a community. And so now I also have my own clinic on Molokai, which is because of my training, I naturally am like, yeah, let's triage that. Let's help you find the language so that you can talk to your doctor, and how can we get you there sooner? Or on Molokai, we've lost 4 providers, 2 full-time, from August 2022 to February 2023. 2 full-time physicians because of mortality, and we lost 2 part-time private physician, nurse practitioner, primary care providers to retirement. It's a population of about 7,000 to 8,000. Some people will question the census just because how do you create census in a rural community? So my clinic even more so was like, okay, if you don't have a referral and you need help, let me help you triage. I don't know if I'm getting reimbursement for insurance, but there's a reality that these people, which I see as my family, couldn't necessarily get the care that they needed in such a short period of time. Because after talking to even some clinic managers, me trying to learn the aspect of primary care for a physician, it's like, how many people are on your panel? How many people as a primary care do you see? And they said that in the new age of physicians, it's anywhere from 5 to 700. In other places where it's maybe a little bit more intense, maybe it's 1,000, maybe it's
3,000.
Right? Crazy, right?
Yeah.
So even me learning these numbers, and then for me to have a referral base, I think it was in after Dr. Aluli had passed away end of November, I looked at how many patients have I seen, because it was when he passed away, I was pretty much the only provider providing care at my clinic.
So I'm actually gonna pause. I'm gonna pause you, because I think that a lot of our listeners which myself included, are not even familiar with exactly where you're talking about. So I actually just had to pull it up on my Google Maps, and I've never been to Hawaii. I know that there's Hawaii, and I know that there's like other islands. So I looked it up on Google Maps, and Molokai, which is what Dr. Genevieve is talking about, is another one of the Hawaiian islands. And just to clarify, that 7,000 to 8,000 population is the population of the island of Molokai. Is that right?
Yeah.
Okay. So what you're saying is when you moved back to, are you from Molokai?
No, so I was actually a military brat. So I
Okay.
moved around a lot. Born
Got
in
it.
South Carolina, lived in Northern California, graduated high school, Okinawa, Japan, dot, dot, dot,
Okay.
dot, dot.
Okay,
Yeah.
gotcha. So this happened to be you got a travel assignment in Molokai and then decided to kind of set up shop there, pretty much. Is that right?
I wouldn't say set up shop. Something kind of drew me to call. I actually was planning on working at the hospital, and I love the integration with the hospital, the access to acute care, the resources. But I think because of how I was raised, I I wanted I wanted to serve the community in a different aspect, in a different light.
Mm-hmm.
I found that more so because it hit home, like, you know, I'm learning more of the facts, being in the ED program, and this ED program is specifically for Hawaii, and their big intention is social justice initiatives.
Mm-hmm.
So I'm starting to learn the stats of Hawaii and seeing kind of the discrepancies of educators, healthcare providers, the percentages of of the people that are serving the general population.
Mm-hmm.
Um, um,
Okay. So in the hospital system that you were a part of or in the clinic that you were a part of, you said
mhm.
there were four providers, so two physicians which recently passed and then two who retired. And they're all, I'm assuming, primary care general practice, like family
Mhm.
medicine. Okay. And
Yeah.
then are you an integrated where do you fall into this clinical practice? Is it a hospital? Would that offers a variety of inpatient and outpatient services? Are you co-located? Can you just describe what the setup even looks like?
Yeah. So for one, the four providers were all different entities. One was at the main hospital. One had his own practice for about
Mhm.
47 years. The other two also were small private practice clinics. Um, for my clinic, it's set up more. I created more based on what was not being serviced necessarily in the community. Like at the time, they weren't doing women's health,
Okay.
right? Um, because there was such a limitation of their services, because the hospital staff 2 to 3, and there is another part-time private physical therapist on island as well. And she's been there for about 20 years. Um, but I just tried to fill in the holes of, like, okay, you're not doing women's health. Okay, there isn't necessarily pediatrics. Okay, so what they would do, they would actually refer out. So like people on island, if it was something they weren't comfortable with as a physical therapist, they would say, okay, you need to fly off island for
You're
this
going to
service.
another island to get care.
Yeah.
Oh my
Yes.
gosh. Well, yeah.
Right. So there was that aspect. And then when there was a huge number, so it's like they also do wound care. So for the physical therapists in Hawaii can do wound care. Um, where, like, there's just a certain legalities, just like we talk about dry needle, but physical therapists are one that can offer that service. And so I was like, I won't do wound care. I won't do, because they have a pool. That I won't do pool therapy for when I don't want to buy a pool, right? Like,
Mhm.
it's just, and even in the economical aspect of like wound care, it's like, for me, it's like usually you're getting referred and not really doing the differential in that sense.
Mhm.
You're eating with it. You are, because
You're
every
doing
time you
you're
get
doing like
it.
wound care debridement, but it's usually by referral from another healthcare professional.
Yeah.
Okay.
Yeah. And I think for myself, it's not, I just didn't have enough experience in
Yeah.
that, where Bree, she does an amazing job, and she's been doing it for so long that for her, it is almost a form of primary care, which is amazing. And I'm like, why learn something that someone's already great
Yeah,
at?
for sure.
Right. So
Especially
like,
when you're living in such a rural place with a population of individuals that don't have very good access, especially to hands-on services like you're discussing. Um, I think that well, first of all, it all comes down to how in primary care, we talk about everybody has different, I'm going in circles right now because I have so much that I want to say. So I'm going to back up.
I know. We might have to have a part two.
I know, seriously. So in primary care, a lot of what we do is we screen, we triage, we assess risk so that individuals can help to reduce risk on their own, or that we can get them to the correct provider, or that we can provide education or care directly to them. Now, that's not limited to a specific specialty. So in primary care, we should really have all of the fundamental knowledge that we garnered from our DPT education and basically just be able to leverage it. And if we don't have specific expertise, because I was just reviewing this yesterday, actually, we have professional scope, which is kind of like what's covered in our professions, like APTA Guide to Professional Practice. Anything that's listed in there is considered a part of professional physical therapist practice. Then we have jurisdictional scope, which is like, okay, well, in some states you can't dry needle still. That's part of jurisdictional scope. So there are certain limitations or certain expansions based on the jurisdiction that you live in. And then there's personal scope. And personal scope is basically what you feel most comfortable with. We should be able to evaluate and assess anything that comes into the door and be able to direct them like, hey, this isn't a PT problem at all. This is your heart. Like, let's take the problem that you're coming in with and make sure you get to the most appropriate provider. And we help facilitate that. So, and then like for things like women's health and pediatrics and basic neurologic needs or wound care, you might be able to cover some of those things, but you're not going to be able to cover all of them. You might be able to, well, some people might be able to cover all of them, but like wound care, for example, I've never done it my entire career. I think that we did that thing in PT school where you sort of like debride the orange. And I don't know anything about wound care. So that is something that, like, as a primary care physical therapist, if I saw a wound, I would be like, hey, I have my buddy on speed dial. You can go over and see him for wound care. But I'm happy to, be your primary consultant for any other like functional needs that you have. So it comes down to like, when the primary care SIG was bringing forward the which probably some people, and I don't know if you even know this, but the primary care special interest group has a primary care specialization. It's underway. We're in our supplemental surveys, and fingers crossed it'll go to House of Delegates and get passed in 2024. But this was presented in 2017, and it looked and smelled and felt like ortho. That's it. It was literally ortho, differential diagnosis and screening. Like, okay, we already have a clinical specialization for that. Primary care covers everything and all ages and stages. But that doesn't necessarily mean that we need to be experts in every single aspect of that. It means that we do our best to screen and take a look at what's in our community and the population that we serve, and make sure that we do have the professional and the personal scope to be able to meet the needs of those individuals, which is exactly what you did. Hey, in Molokai, nobody's doing women's health. Nobody's doing peds. Like, let's make sure that those needs are addressed so that this population of individuals has good access to care if and when and why they need it. I love that.
Thanks. It's humbling in a sense, and to, like I said, that's where it's like I have so much experience, but I feel like it's well, I am a student. I'm in the edu program, but I'm so early in the stages as a business owner. I mean, now I have 2.5 providers with massage therapists at my clinic. I'm able to be on a waffle on a completely different island for a duration of time, just to be able to do that. And then now, even as a primary care mentor, because I have a new grad in my clinic, and to be able to analyze his notes and see, sorry, Gary, to put you on the spot because obviously you're here. But anyways, like reviewing a note that someone came in for a fracture, and I looked at the medical, I looked at the subjective of his note, and then I looked at the medical history, and they came in for a fracture, But then I saw they had anemia, they had dizzy spells, and it's
Yeah.
like, where in your questioning as this note shows that you ask those questions,
And
are we,
addressed
yeah,
those
like,
aspects of fall risk and
yes,
fall, yeah. Yeah.
right. So it's like how did you not consider that? Or there was another case that I remember having, that somebody had a history of cervical myelopathy. I think this was a couple years ago in one of the travel clinics.
hmm
And I acquired one of the patients, and I was like, okay, so this person had a history of myelopathy,
hmm
and now they're coming in because they're fall risk and they're having imbalances. Like, there's no documentation of a Hoffman or a Babinski and reflexes and Romberg, but
Like, is their
I can,
myelopathy progressing? Which typically it
yeah,
does.
yes, right. So there's like how, like, what are we not teach, if that's our fundamental practice, which puts me in this conflict, even to really, like you said, I like that there's a SIG or a like specialty group for primary care, because I think there are metrics that need to be pushed forward, or testing or credentialing or certification, to allow people to be in this position. Because
Mhm.
it's like, how are we fighting, like, seeing how many new grads that come out that don't grasp that idea
Yeah.
is,
Um,
it's
yeah.
tricky.
Yeah, it is tricky. And so I really think it depends on the student and it depends on the program.
Yeah,
CAPTE has their accreditation standards. Good job, CAPTE. Thank you. That is minimum criteria for what we need to, or in order to have good curriculum for entry level DPT education. Everybody needs a standard.
yeah,
That's great. But it's not like it's not like CAPTE is gonna like be in every single classroom and know
yeah,
exactly, they accredit the program in general. They don't necessarily accredit like individual little things and objectives about programs. So you can have a program that perhaps is led and directed by individuals or groups of individuals who are really old school, and maybe they are really teaching the art and the practice of physical therapy as it used to be. You receive a referral, this is what you do for treatment, and they focus on this treatment heavy aspect, even though we know that like CAPTE standards, we have to include all of those differential diagnostic
yeah,
components in our curriculum, and it's covered on the national licensure exam and everything. But I think the problem is clinical education. So
yeah,
we have seen a significant evolution in our profession from, a certificate to a registration to a bachelor's to a master's to a doctorate in a relatively short period of time when we're talking about the way that other professions have evolved. And when you have people who were used to practicing exclusively under a referral, and it was treatment heavy and there wasn't differential diagnosis and they weren't doing the frontline decision making, and then you place a student who's supposed to know all of that stuff and who's probably very eager to learn all of that stuff,
yeah,
you place them in an environment where they're supposed to learn from each other, or the CI is supposed to kind of teach and guide the student. But then the CI is kind of focusing on treatment and focusing on this is what you do with that, and not so much focusing on when you get a patient that has never seen anybody before, or because most of the massive red flags that I've ever seen in my career have been from referrals, because
yeah,
stuff happens. Like
yeah,
sometimes it takes 3 weeks for people to get into physical therapy, or they received a referral a month ago and they just haven't got in, and stuff changes overnight. Blood pressure changes overnight. So it's about the modeling that clinical instructors and clinical education sets. And then when students start graduating, they get into clinics that again are still kind of practicing in these old school models. So then it's like, okay, what's your clinical reasoning with anything that you're doing? It's almost as if there's no what's the word for it? There's no like accountability in that first year or two, because practice patterns are kind of all over the place. And this isn't just limited to physical therapy. It's a lot of different professions that are going
yeah,
through this wave of like old and new. So have
yeah.
you seen any of that?
exactly. Yeah. And I think that's the struggle, honestly, that I feel, and the conflict that it's like I feel like all of us are in this infancy stage, and how do we, that for me, that's where it's like, I can only, not to go on, it's like I'm trying to be the change that I want to be, right?
Yeah.
That's why I created the clinic space that I did, and why I'm in academics, and taking the time to get my ed to start understanding more clinical, or like from the standpoint of education, of our limitations, right? Because education is our model to teach,
Mm-hmm.
right? So it's like our specialty is physical therapy. So how are we going to implement these changes
Mm-hmm.
so that
On a
we can
large
better
scale.
serve,
Mm-hmm.
right? Because it's like, I think it's easy for us, as even as an organization for APTA, like even being part of these policies, it's hard. Like, and I'll be very blunt. Like, I actually stepped down because I have a lot between the ED program,
Yeah, for sure.
personal loss, all these different things. But because of the policy, honestly, I couldn't actually fully step down as delegate. So that's,
Okay,
you know,
so
so
now,
like
so
part of
let's,
my positions, right,
yeah,
is kind of like by default, but I love the motions because, I have to give full credit to Dr. Doug White to like a lot of things. And he's kind of just tapped in to say, hey, can you review this? And I'm like,
yeah,
hey, I'm getting hosed down by a fire hose. Give me a
yeah.
moment.
Yeah, so first of all, good on you
6:30.
for knowing when to say no, knowing when to
Yeah.
step down. I've done this recently. Also, I've had a lot of things going on with my family's health. Just again, drinking from a fire hose. That is exactly the
Yeah.
position I've been in. So good on you for knowing
Yeah.
when to do that. That's a sign of professionalism and maturity. And I think that that's important, because I think sometimes people set this example that like, you got to say yes to everything, or otherwise you're not going to be successful, or you're not going to,
Yeah.
succeed or get things done. And that's not the case. Sometimes the slow game is better. So that's my first point. My second point is, let's tell our listeners a little bit about this motion and how it works. So you're a Hawaii delegate?
I am. So I was originally chief, but I stepped down. So I'm actually serving as the second delegate.
Mm-hmm.
It's it's really empowering. Like I like to see what I saw 2 years ago when I was able to go to the house when Doug was mentoring me, to now actually putting in the motion and seeing the importance, really, of those subtleties of language, of one word to the other, how many
Mm-hmm.
drafts you go through,
Yeah.
throwing it to different colleagues, and like, how did you read this, and how did you take
Mm-hmm.
this, and then trying
Yeah.
to meet the deadlines. Like,
Yeah.
I'm like, oh geez, like, even I'm supposed, like, I forgot about the, I told you, I was like, I forgot about this. And then like Doug asked me to get back to something and I haven't, because I have an assignment due.
Yeah.
And, there's just all these different things. But anyways, submitted packet, we submitted for packet 2. So now we're trying to get any other edits and changes, because
Uh-huh.
I think we have a virtual meeting coming up I think it's in July.
Uh-huh.
So it's just very, like,
Lots of moving pieces.
lots of moving
Yeah.
pieces for a lot of different people.
Yeah, so I want to back up and just explain what the House of Delegates even is, because I think a lot of people, and I didn't even really have much of an appreciation for it until about 2 years ago. So the the APTA House of Delegates, we're not talking like United States or state level. The APTA has its own House of Delegates. Each APTA state chapter has a certain number of delegates that are responsible for bringing forward motions to represent their state and their constituents on what the needs are in order to advance the physical therapy profession. So as when you get voted in, when you get elected as a delegate, your team is responsible for hearing the voices of of your state's constituents, and then bringing forward motions to the APTA in order to set forth advocacy efforts and other motions that can then basically go from the APTA level out into actual public legislative efforts and other advocacy efforts. So in Hawaii this year, Genevieve, and like she had mentioned, her partner, Dr. Doug White, brought forward a motion related to physical therapists as primary care providers. and wanted, and the charge to the APTA was to more clearly identify what is the role and the competencies and the way forward of the primary care physical therapist. So, and if, correct me if I'm wrong. So go ahead, now that I've explained that so people actually understand what we're talking about here, go ahead and talk about this motion.
Yeah, so I think the big premise in it just the way you had explained the struggles of the different schools, the different CIs, because we all come from different lines of thinking,
Yeah.
is right now primary care almost comes off very convoluted, right? Like,
It does.
and that's the struggle. Like,
Yeah.
even being, as I'm learning more in the Ed D program in this day almost 8 of, or day 7 of intensives, of like, there's an ambiguity that has to happen so that we can be flexible for the whole, if that makes sense.
Yeah,
Right.
certainly.
So there's that question of like, how specific are we so that can we be without pigeonholing us in a place to do something we either don't want to do, but obviously specific enough so that it really implies what we do.
Mm-hmm.
And so it's like the best way I can explain like some of the language that we use is like, yeah, my mom worked Department of Defense. If I told you what you did, I'd have to get rid of you. You know what I mean? So it's like there's nothing really like we create this identity with our profession. And so like then the question becomes, even with the language as we're kind of going back and forth with the primary care motion, is like how I don't know how to say this. How do we have it serve? Because it's a blend between primary care, but also the charge for rural health, which in a sense go hand in hand. Right. Because even in the context of what you share, or where compared to where me and Doug practice, right? Like we have such limited resources. Do we want to tell someone, can I phone a buddy that's to be able to do that? No, they have to either go off island or if they have to drive 4 to 5 hours. Right. So it's like how can we serve that niche of population and put the right languages for the outside people to see our value? And so like I think within our profession it makes sense, like and other people may know. But when we're writing a policy, how do we, when physical therapists aren't even recognized as federal providers, and we can't even get the flown reimbursement, then we're not even seen as providers, let alone primary care providers.
Right. So, and okay, so here's my take on this. So you're wanting this motion, the language in this motion, to ensure that it is inclusive of anybody in the primary care space. And to me, the primary care PT space is like an umbrella, right? So if you have this big umbrella, primary care is the umbrella, and then you have like subsets of different types of populations and different aspects of care that fall underneath that. And rural health is certainly one of them, but you can certainly practice primary care PT in more of an urban or suburban metropolitan setting, or area. It's all about access to somebody who has a prime focus on population health and multi-systems comprehensive care. Just like in orthopedics, you've got ortho, but then you've also got like your foot and ankle specialists and your hip specialists and your running specialists. And, it's all ortho, and every running specialist is probably considering the other systems, but it just gets more and more nichey. So I understand what you're saying in that in drafting this motion, you wanted this language. It's like, we don't want it to be too broad, but we don't want it to be too specific. And I think that initially starting out, in fact, the most recent draft that I saw of the motion, I thought all of the edits from the original draft were like spot on and exactly what they should be, because the first motion was more musculoskeletal diagnosis from what I remember, and I could be mixing it up with something else, but it definitely seemed more like direct access musculoskeletal. This most recent one was much more focused on population health and being more expansive in that primary care role to meet the needs of whoever comes in your doorway. Like, we should have the basic fundamentals of being able to work with somebody who has back pain but also has COPD, and being able
Yeah.
to do those things. And then again, then you bring in your personal scope, because your personal scope could be like, oh, I have a stronger oncology background. I have a stronger orthopedic background. I have a stronger, just like primary care physicians, sometimes their bread and butter is women's health. Sometimes their bread and butter is um, more lifestyle medicine. Sometimes their bread and butter is cardiovascular disease and diabetes. So
Yeah.
like you don't necessarily, just because we're starting with the terms primary care does not mean that everybody underneath that has to be, an expert in everything. But the
Yeah.
language that was the way that this motion has developed, I think has developed for the better to support the primary care specialization. And I think once we have the primary care specialization and we start showing a a record and a history of primary care specialists working in these types of settings, that's going to push the ball forward to bring physical therapists into those that can be recognized as primary care providers under CMS. That's how I
Yeah.
see that trajectory going.
Yeah. It's awesome. It's awesome to have this dialogue and connect. Like I have to thank Steve for connecting with us together,
Yeah.
because it's like I said, I'm so busy in my community fighting the fight for what we're trying to do globally for the people, right? Because
Uh-huh.
that's really what it is. And so to see all the things that you're doing, we're just like, okay, we're definitely traveling in parallel roads, and so it's very cool.
And it's
It's
very good for us to stay connected and for us to keep bringing our internal PT primary care community together and find good ways to do that where it is accessible in our crazy busy lives. So one way you
Yeah.
can do that, here's my little plug. One way you can do that is by joining the primary care special interest group. For those of you that are APTA members, $25, join APTA Federal, just add it as a section under your profile. And then you can join our primary care SIG from there. You can also go onto my website, redefinehealthed.com, take a look at some of the courses, and I'm going to have a lot more stuff coming out specific to what our competencies are. I also have a couple of papers in the works related to what exactly is primary care PT. What are we considering this? What does it look and feel like? What are the differences in different types of settings? And what are the different operating models that you can function on in team-based settings? So lots of stuff coming out over the next year. I know we're kind of running up on time here. So Genevieve, how can people find you if they want to reach out, if they want to connect with you?
I my clinic does have a website. It's Molokai PT and Rehab.com. I think that's what it
Okay.
is. I do
Yep,
have a
I'll link that in the show notes. And I see you've got an Instagram here and
Yeah, yeah. I do have kind of my own professional. I haven't really been sharing or doing much more motivational, inspirational, but it's g.fitness.dpt. It's my IG. But I've
perfect.
been so busy that I'm like just working in the dark.
You know what? Someday, and I honestly like I say someday you won't be busy, but I get the sense from you based on your background that that's never really going to be the case. And I can relate to that. But you know what? It's good to stay connected anyway. So hopefully we can just keep this conversation going. Thank you so much for coming on the show. I know you are very busy and have a lot going on, but I think that this conversation that we had will be really helpful and really useful to a lot of people. So thanks so much for coming on. I really enjoyed our talk.
Awesome. Thank you so much.
Okay, so this is a follow-up. I'm coming back at September 12th, 2023. And this is a follow-up to everything that we had discussed with Dr. Genevieve a little bit earlier in the summer. At that point, the Hawaii delegation had brought forth this motion for the APTA to more clearly define the practice area of primary care physical therapy. And I just wanted to provide an update because we had mentioned that we were going to do a follow-up episode. And this is really kind of where the update stands. So in July-August timeframe, when this motion was brought to the APTA federal delegates, they took a look at it and they were like, well, wait a second, isn't the primary care clinical specialization already doing this, already putting forth the effort to help define the practice area, writing the description of specialty practice, et cetera, et cetera. And it was interesting because as, I knew about this and we even mentioned it in the podcast episode, but all of our board members in the primary care special interest group, we were more, and I don't want to speak for them, this is really just my interpretation of what happened, but all of us were like, oh, well, when the Hawaii delegation brought forth this motion, we were like, oh, well, this only kind of will strengthen our position and, where the petition is with the ABPTS clinical specialization with primary care. And then it was brought to light, or, someone sort of spun it a different way and was like, well, we don't want this motion to necessarily go through and then a whole nother, task force or committee or group of people start something that then won't fall into alignment with what is already happening with the primary care petition. So pretty much then, when I reflected on it, I was like, you know what, that actually makes a whole lot of sense. Like, we don't want to first of all, we don't want to create unnecessary work, but we also don't want there to be two separate, definitions or practice areas that are defined in primary care PT. We would like for it to all be consistent. So it only made sense to ask the Hawaii delegation to just table the motion for now, which might actually end up working out better because we are at the point where we are done with our supplemental surveys for the primary care PT clinical specialization, which is awesome. So we're kind of in this analysis phase, and then hopefully tying up all the loose ends on the description of specialty practice and the competencies and all of that, so that hopefully it can go forward to the House of Delegates in 2024. So that's kind of where we're at. That was just a follow-up to the motion. I don't think that the Hawaii delegation being asked to table it for now, I certainly don't think that it was the wrong move or the wrong idea. I think that there was conflicting interests, or not even conflicting interests, but there was already a project underway that was addressing this. And unfortunately, in my opinion, it's just been sort of almost kept undercover. Like, if you go to the ABPTS website right now, it doesn't say that there are any clinical specializations that are pending or, in consideration. So really nobody knows about it unless you have heard other people talk about it. So hopefully we can bring more awareness to the idea of it, and we will see it come to fruition hopefully next summer, fingers crossed. So hope you enjoyed this episode and also this little follow-up. Stay tuned for more podcast episodes, and please hit that subscribe button. And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPTPodcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.